Good morning, everybody. I'm Christian Escobar, the president of the Coronado Roundtable. Happy to see so many of you here this morning. So we'll get started here in just a moment. If you haven't already done so, you still have time to get a cup of coffee. Pardon me? It is. I just need to get it up to my mouth. Okay, so I'm Christian Escobar, president of the Coronado Roundtable, and happy to see so many of you here for a very informative program this morning. We featured Dr. Phillips, a retired heart surgeon who lives here in Coronado. Before we start the program, if you would please stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. As you know, our programs are recorded live for Zoom. And for that, we'd like to thank the Coronado Public Library and its staff for continuing to provide this service for us and for the community. And for that, especially, we'd like to thank Selena Valladolid there in the back, managing the recording and the AV services. For those of you at home, please mute your computer or device, and please also turn off your camera. You may use your chat box for the Q&A portion of the program that will follow. The recording will also be available on the library's YouTube channel following a few days after the program today. For those of you in the room, please also silence your cell phone. Our coffee this morning is provided by Alex of Amalo Brew, the coffee cart service. And we do ask for a $3 donation if you care to do that, or even a donation just to help us support these programs. I would like to note, sadly, the passing of one of our past board members, James Kelly, retired naval captain, longtime resident, a writer who wrote all about these programs for the Coronado Eagle and various press releases. Jim, as we knew him, was a great person to have on the board. He was, of course, a retired naval captain, but also had a PhD in education, had a career in the Navy, had a career as a teacher, a career as a banker, and was an all-around outstanding individual in many fields. So his services will be at the Sacred Heart on September 3rd. Our next program you will not want to miss. That will be on September 26th and will feature Kevin Danino. He will speak about San Diego's CCOE, which is a cooperative that mobilizes businesses, academia, and government to grow the regional cyber economy and to create a more secure digital community for all. So that's September 26th. But now to introduce our speaker, our own Coronado Roundtable board member, Dan McClure. Dan, you come up.
Okay, thank you, Christian. Hi, I'm Dan McClure. I'd like to introduce to you our speaker today, Dr. Stephen Phillips, a retired heart surgeon. His talk will discuss how the diagnosis and treatment of heart disease in women is very different compared to men. In the 1970s, Dr. Phillips and his team introduced a new and life-saving treatment for evolving heart attacks. That treatment was emergency coronary bypass, artery bypass surgery. Following his retirement from his practice in 2000, Dr. Phillips was appointed to the National Institute of Health as director of the Division of Specialized Information Services. So his division provided open source authoritative information on areas of disaster preparedness and response, toxicology, hazardous substances, environmental health, climate change, disease surveillance, and related subjects. In 2006, Dr. Phillips and his team became part of a government-funded multi-agency to create a reproducible and scalable hospital surge model for the US to respond to man-made and/or natural disasters and pandemics. He served in the US Army for 31 years, deployed twice to Vietnam, and retired as a reservist lieutenant colonel in 1993. He is married to Susan Zeff Phillips, has 5 children, 9 grandchildren, and lives here in beautiful Coronado. So let me introduce to you Dr. Stephen Phillips.
Well, thank you, Dan. I think my mother helped you write that introduction. I'm delighted to be here, and I thank the library. And I was very saddened to hear about the passing of Jim, who was just a terrific educator and wonderful person. We may have disagreed on some of the politics, but that does not matter. That's important. I'm doubly delighted to be here today. One, to talk about a subject which is kind of dear to my heart. but also, I don't have to play golf this morning. Our tea time was canceled. And that's something that, if you saw me play golf. Anyway, heart disease in women, it's a very, very different process. The healthcare community, the medical community, has really neglected the symptoms and the problems that women have cardiac-wise. Not on purpose. We just assume that one shoe fits all in very many of the medical areas. For example, we treat pneumonia the same way, which is okay, and it usually works and it cures people. But we're all different, genetically, physically, size-wise, and respond differently to treatments. So let me just go through this statistics and some information about recognizing heart disease in women and the management that we have today. We have a long way to go, but we're getting there. Now, I don't want to scare anyone, especially the ladies, because it's going to be a little different. And I will say during the Q&A, I'm happy to answer questions, but please don't ask me about personal issues in public, because it's unethical for everybody else to hear about that. I'm happy to talk to you afterwards. So what I'm going to talk about today are some statistics, the risk factors that women face, the symptoms that you have that are different than men's, how we test women, and how we diagnose their heart disease. And again, what treatments we may have. Now, I'll just go through this very quickly. Heart valves, heart rhythm, and arteries. I'm going to focus on the coronary arteries. Now, for some reason, and I don't think anyone can explain it, women tend to have more problems with their mitral valve, men with the aortic valve. No particular reasons, but I just throw that out as information. If you're a woman or a man and you have a valve problem, it's probably one or two of those. Heart rhythm, which we all at our level of age, young age, have some sort of issues with heart rhythm. There is really not a gender difference in heart rhythm. The most common abnormality of heart rhythm is atrial fibrillation. Oops. Serena, I broke it. Let me go back. How do I get back to that one?
This one, right?
I did much better in the operating room. As I said, the most common rhythm is atrial fibrillation. And for a long, long time, we thought that men were more prone to having that than women. But it's not true. This is a very strange finding that taller women seem to have more events of atrial fibrillation than shorter women. And the numbers that are in the literature is that you have a 3% higher chance for every inch taller that you are. I mean, why? Don't ask me, please. I can't explain it. But just real quickly, this is what a normal electrocardiogram looks like. And this is what atrial fibrillation looks like. I'm just throwing this out for your information because I know some of you are probably in this situation. Well, let's talk about just some comments about heart disease in general. The death rates from heart disease has dropped from the 50s to now to by 65, 70%. Deaths from heart attacks have decreased from the 50s to now about 90%. And that's because you all know about stents and intervention when you're having chest pain, and that's made a difference. Deaths from arrhythmias have increased, but only about 4%. So even though the single most common cause of death among men and women is heart disease, the causes have changed. Now, again, you all know this, but I just want to emphasize some risk factors that are very important. Unrecognized hypertension is the worst possible thing that someone can have related to heart disease. Smoking is second, and the blood lipids, the fats are third. And you all kind of know this, but please pay attention, especially to the high blood pressure. Smoking is going to be up to you. Thank goodness it's being almost eliminated. And we are paying attention to our blood fats. Now, there are many types of blood fats, but the two major types are the low density lipoprotein. That's the bad one. That's the lousy L cholesterol. And the high density is the good cholesterol. Oops, I did it again, Serena. All right. Want to get to that one. Okay, thank you. Just quickly so you know, we want to kind of keep our cholesterol below 200. We want our LDL to be less than 100. And we want our HDL to be 40 or higher. And our triglycerides around 150. I mean, you all pay attention to this and you all try, and there are many different things that we can use to do this diet, chemicals, and so forth. Well, let's move on to heart disease in women. Heart disease is the #1 killer of women. 1 out of 3 women in America will die of heart disease. Again, I don't want to frighten you. I want you to be aware of this. It kills more women than all cancers combined. I know we worry about cancers, but remember, heart disease is the #1 killer. And most women are not aware of their risk. Surveys have shown that about 50% of women do not even recognize the fact that they're at risk for heart disease. As opposed to men, 80% of female cases, and again, it's hard to get your head around that, 80% are preventable by lifestyle changes. And I'll go through this as we go on. Now, men generally experience coronary artery disease about 10 years ahead of women. Why? Well, we kind of think estrogen protects you. It keeps the arteries a little more flexible, and it helps lower the blood fats. And I'll get into estrogen a little bit later on. Now, there are sex-specific risk factors that women have that men don't. And some of these are unrecognized. Early menopause leads to early heart disease in women. The hypertensive disorders of pregnancy. Men don't get pregnant as far as I know. When you have eclampsia, retaining fluid, your blood pressure goes up. Even though you may control it later on after delivery, you still had that episode and that still has damaged. Polycystic ovaries. Again, as far as I know, men don't have ovaries. Why? It's just an association, a statistical association. But in women, also, there are a lot of psychological risk factors. Women are abused, sadly. We know that, can be abused. Socioeconomic deprivation, not understanding health literacy, environmental risks. These are emotional things that affect women. Why we don't know that do not affect men. Symptoms in a woman are quite different than in a man. They can have the same symptoms. We all can have the same symptoms of there's an elephant sitting on my chest, there's a pain down my arm. But women often have different symptoms. Well, we all know this guy. Heart attack symptoms, as I said, can differ widely than in women and in men. Now, non-typical chest pain, pain in the neck, in the jaw, in the back, or somewhere else can be a symptom in a woman, very unlikely in a man. Fatigue, unusual fatigue, and I know you ladies work hard, you're taking care of families, you're doing something and you're tired, but if it's above and beyond normal, be alert. Shortness of breath is a very common symptom in women. It can happen in men as well, but it's more common in women. Nausea and vomiting. So pay attention to that. If you have sudden dizziness, heartburn-like feeling, cold sweat, unusual fatigue, unusual pain, go see a doctor. Don't delay. Be alert to that. Now, why are these differences? Well, they're all over the place. Estrogen protects you before menopause. 1 million women roughly go through menopause every year, and replacement therapy treats most of your horrible symptoms. But does estrogen really protect? Does it protect coronary artery disease? Well, we don't know. The literature has been on a roller coaster ride. One day you'll read a paper that it protects, another day you'll read a paper that it doesn't protect. So don't depend on hormone replacement therapy to protect you from coronary disease. I'm not saying not to use it, obviously. It's very important for your symptomology, but it may not protect you. The literature is still out on its efficacy. Now, why are the symptoms different? Well, we try to explain it by the anatomical differences between men's hearts and women's hearts. Women's hearts are smaller, their walls are thinner. That means that if you have high blood pressure, you can damage the heart muscle more easily because it's thinner, and you can reduce the blood flow to the heart muscle. Women typically have smaller coronary arteries. A woman's artery is about half the size of a man's. That's just the way we're built. So smaller main arteries can lead to more disease in the microvascular circulation, which is the capillaries and the arterioles. I don't want to get too technical with names, but just in the smaller blood vessels, not the major blood vessels. Now, if you look at a man's artery, and see if I can get this. I wanted to get the point of the word. There we go. If you have a clot that blocks a man's artery by 50%, it doesn't really reduce the blood flow very much. A 50% block can grow, but 50% narrowing will not reduce blood flow. The same size clot in a woman's artery, because it is smaller, will reduce blood flow by 75%, and that's significant. So, just keep that in the back of your mind that you're more prone to have trouble if that happens. Same size clot, different size vessels, different flow. Men and women build up their cholesterol in different areas. A man will build a cholesterol plaque up in the large major artery. Now, I'll just digress for a moment. The arteries, the main arteries, lie on the surface of the heart, and they send branches into the heart muscle so that blood can flow there, just like a tree trunk and branches of a tree. When the heart beats, the main arteries are bent. They bend, that's normal. And over time, you get microfractures in the wall of the artery because of that microfracture, and then calcium may build up, and then you get a plaque. And the plaque can be stable. We all have plaques that can be there for our entire lives without any difficulty. I just wanted to throw that out because cholesterol is not necessarily 100% bad. It's useful. Now, in women, they are more likely to develop disease in these smaller arteries, which are much harder to treat. I mean, how do you clear out one of these little branches that are adjacent to heart muscle cells? You can treat this, and we'll talk about that in a minute. Now, on standard tests, no longer does one shoe fit all. Men and women can have different signs on standard tests. Now, we have a bunch of diagnostic tools, and I've broken them down into the anatomical. These are static. You can have a certain type of scan, and it'll give you a score of how much calcium you have in your arteries. You can do a nuclear scan, which will show you where that nuclear material flows in your heart muscle. You can do an angiogram, which is a gold standard, but it's also a static test. It doesn't tell you functionally how you would do. Now, we have functional tests, treadmill, stress echo, which is a picture of the heart when you're running on the treadmill, and it shows how the wall is beating, whether it's beating well or not. And it's the same with the nuclear stress test, where it shows you where the nuclear material is flowing and whether that wall where the nuclear material is or isn't is moving. Now, what can happen in women when they do a nuclear stress test, if you have small vessel disease, which is diffuse, all of the muscle is involved, the nuclear material will be equal or unequal in those areas. And the doc may say, well, okay, it's normal because I could see the nuclear material everywhere. No, it's a false positive because it's equally being resisted. The flow is equally being decreased to those areas. So the nuclear test may not work. Now, what's coming into being are these functional tests. And I don't want to get too specific, but you can measure the blood flow through a coronary artery above and beyond an obstruction. It's called a functional test. It tells you how much reserve you have. If you're lying on the table and you're having an angiogram being done, and it shows, well, that's a 60 or 70% blockage, you're just eyeballing it. You can put a little catheter down past that blockage, measure pressure differential, and understand that functionally it's not going to help. You're going to be in trouble. Now, a treadmill test, standard treadmill test. Many of you have probably taken these. I have. Men typically will have chest pain, EKG changes, and the test gets stopped. Women usually will not have chest pain. They'll say, hey, doc, I'm really getting tired. And their heart rate will increase. And that is a sign of heart disease in a woman taking a treadmill test. And hopefully the person monitoring the test will know that. Angiography, as I said, is the gold standard. Now, men and women can have the same types of blockages in their main arteries, but women tend to have it less often. Now, this is an angiographic picture, and the arrow demonstrates a main artery that's totally blocked, totally blocked. Now, that's large vessel disease, and we have treatments for large vessel disease. We have coronary bypass surgery. You can see the blockage here and the vein going from the aorta, the main blood vessel, shunting blood past the blockage. Stents, you're familiar with that terminology. It's a little catheter with a balloon and a wire mesh on it that blows up, smashes the plaque, and the stent keeps it from collapsing back again. And here is a picture of an artery with a blockage. And here it is after the stent. That's mine, a couple years ago. It hasn't helped my golf game, though. So a normal angiogram in a woman needs further evaluation if they exhibit symptoms of coronary artery disease. You have to look for disease in smaller arteries. And that's not easy, but we do it by, well, okay, I didn't mean to show that. Okay, we do it by heart scans. There are a whole host of different heart scans that can look for inflammation in these arteries. Now, how do you treat women with coronary artery disease, especially if it's a small vessel disease? Well, we don't have a mechanical answer like we do for the main arteries. But there are sex-specific strategies to help women for better outcomes. Now, again, these are difficult things to do, but 80% of women can do better if they follow these lifestyle modification changes, stop smoking. There's a 25% higher incidence in heart disease in women who smoke than who don't smoke. 1/4 who smoke have a higher incidence. So do what you can to stop smoking or encourage your mothers, daughters, whatever, to stop smoking. The Mediterranean diet has shown to help for both men and women, but even more for women. Weight management, critical. And I know you're always looking in the mirror and saying, oh, is this fit and whatever. And guys kind of do that secretly, but women do it overtly. Physical activity is important. I mean, your Apple Watch or your Fitbit, whatever, it doesn't have to be vigorous activity. Walking is one of the best activities, but do it as a routine. It's a combination of things that we have to do at this point. Stress reduction. Why? I guess for some reason women have more stress than men. Probably because you're taking care of us and we cause all that stress. There are different pharmacology treatments depending on what your doctor finds and what you have. And I might mention that another risk factor that women have that men don't are these connective tissue diseases, these inflammatory diseases like lupus and arthritis and that whole category, which are much more common in women. But to get back to the therapies, there are different categories. There are blood thinning therapies, which will help, especially for the small vessel diseases. The antiplatelets. Platelets are the main culprit in causing our block. You have a little cholesterol plaque that breaks. Platelets go there immediately to try and plug up that little break, and then the artery clots off. A daily aspirin, 81 milligrams, has the same antiplatelet effect as the regular size aspirin. So I'm sure your doctor will recommend one of those every day or every other day. Statins. Statins have been underused in women. Why? Because women have not been diagnosed as frequently as men. So aggressive use of statins, if you can tolerate statins, it doesn't cause you muscle aches and pains. And if statins do, there are alternative therapies that can do that. Make sure your blood pressure is under control. If you take your blood pressure, if you have a machine, you can't become hysterical about it. You can't stop living. But I would recommend, if you can, take your blood pressure in the morning when you wake up, and then at night when you go to bed. Now, morning blood pressures are typically higher, but for us in this room, a blood pressure of 140 or less is okay. Now, American Heart Association changes its mind every other month. So, but they're not age-adjusted recommendations. At our age, a blood pressure of 140, 130 is okay. And of course, if you're exercising in certain periods, your blood pressure will go up. That's natural. You don't want to pass out if you're doing something like playing pickleball. And of course, there are other things, especially to help relax blood vessels, beta blockers, calcium blockers, not necessarily for chest pain, but if you have small vessel disease, and this is also small vessel disease in the fingers, like Raynaud's, you know about that. You take those, and that helps your heart. And of course, if it's serious, if you're diagnosed, you want to be on anticoagulants. And there are a whole host of those that you can take. Cardiac rehab, very important. If you have a diagnosis, cardiac rehab has been underused in women because the diagnosis has not been made as frequently. So if there's any indication, now cardiac rehab doesn't necessarily have to be in a gymnasium with an instructor. You learn what to do and then you do it on your own, but you have to do it. Women sometimes need to have mental health advice about reducing stress. Again, stress is a significant contributor to heart disease in women. We don't really nail down exactly why women seem to have more stress. I mean, tongue in cheek, it's us, but there are other things. They're raising families and they got the kids off to school. I mean, it's a very low level, constant stress, perhaps compared to men who have stress as well. And you basically have to customize your activities and your medication to you. Now, we're getting toward personalized medicine because everything is genetic. We're all a little different. We all respond a little differently to medications, to activity, to stress, or whatever. We're not there yet, but we're heading that way. And hopefully, we'll be able to continue the research into those activities. I want to leave you with, a couple of messages for ladies, for gals. Know your risk factors. Know about your pregnancies, your blood pressure, your autoimmune diseases, your inflammation, your stress. It's above and beyond what men exhibit. Recognize the warning signs. If you're not feeling well, if something comes on suddenly, I know it's a pain. It's the most least favorite thing that you want to do is what you should do. I mean, if you have a decision to make about, do I do this? Do I do that? Do I do this? Probably, if you're not feeling well, the least favorite thing to do is to go to the emergency room, but you should do it because it can really make a difference. Get regular checkups. Your doctor will know you, notice changes that you may not know because you adjust your lifestyle cycle. You downsize your life events to fit with your symptoms, but your doctor will ask you, how come you can't climb a flight of stairs now when you did last year? Or how come you can't vacuum the house any longer? Or it's more difficult for you. So see your doctor regularly. And again, overall, make hard, healthy decisions. I know you know all this. We don't always practice what we should do. I mean, I don't, but that's nature. Well, I'm just finishing up with this. Heart disease doesn't care what you wear. Okay. But it does care what you know. And thank you very much.
Thank you very much, Doctor. That was very informative. We'll take a 3-4 minute break for coffee, and then we'll go to a question and answer period.
Now I'm going to be on the stretch.
Can I get your attention, please? We will be starting the question and answer period. And not yet. Not yet. If I can get everybody back to their seats. And Mike will be passing around the microphone, but before we begin the Q&A, let me just say, please, no questions of a political nature. And I know the subject is not, but you never know where things wander. So, Doctor, if I can give you the mic and we'll take it from there.
And please do not shout out your question to Dr. Phillips. Raise your hand. It takes time to get around to everybody. I'm going to go to the back right here first.
Good morning. Thank you for that presentation. My name's Sue Stephen. I worked in the pharmaceutical industry for 20 years. And the reason they didn't test a lot of drugs on women is it would cost twice as much. The question I have today, though, is do you think there's parity today in what pharmaceutical industry is doing regarding health drugs for men and women?
Well, you never took me to dinner from my office or brought my office lunch. No. You're not a rep. I know. No. The pharmaceutical industry is terrific. I mean, they do basic research. Is it working now?
It's working.
I support the pharmaceutical industry. I always listen to the folks that would call on me that were trying to sell or have me use something. The science is fantastic. They do receive money from the government to do research on vaccines and other things. There are, political and bottom line issues, drug costs, and so forth. But I think the industry doesn't really have 100% control over the cost because whatever chemicals they buy to make their medications, they have to foot the bill. So I know we see information and read articles about how it's so much cheaper in Mexico or Canada or other places. And it is, but they have a different regulatory system and a different cost structure. We have to work on it. Did I answer your question?
No. So I think you're referring to the pricing. So when you do a clinical trial,
So when you do a clinical trial, you're trying to minimize variation in your population so that you're really studying what the drug is doing and not just what the genetics are doing. And so traditionally they would only study men because that was one variable that was removed. Then, of course, there were all these reviews of how women had heart disease. And so they started making sure that they were studying women. And so my question today is, do you think it's equal now? Or do you think that the women have a longer way to go to get parity in studies of new drugs in women?
It's still not equal. In my mind, it's still not equal because when I was at the NIH, I was involved in reviewing a lot of these clinical trials, and there were more men no matter what. Now, it was perplexing as to why perhaps women are a little too busy sometimes to contribute to a clinical trial. We are now, or at least when I was working, we're doing women-specific clinical trials, asking for more women to join, especially if there's more of a woman-female-related issue. But broad-based, like cancer, heart disease, or some of these other issues, it affects everybody. So it's not equal in my mind.
Okay, next question.
Sorry, I couldn't hear.
Yeah.
I turned my hearing aid up.
You mentioned hypertension. Is the risk similar or different when you have hypotension, like blood pressure 100 or lower?
Low blood pressure, like POTS or something like that. There's something called the critical closing pressure of a coronary artery. In other words, any flexible vessel that has something flowing through it, like blood through an artery, if the blood flow decreases to the point where the walls of the artery constrict and collapse. Low blood pressure, I mean really low blood pressure, you're in shock. Statistically, there aren't as many people with low blood pressure low enough to cause a shock or a disease process as there are with high blood pressure. So I didn't really answer your question the way you wanted to know, but there is no real answer because there's not a lot of statistics on it. But I would just have to assume that if it got too low, it's just as dangerous.
Okay, next question.
Doesn't increase the risk of like clot or something.
Oh, no, the blood pressure doesn't do that. It just, the artery can just collapse, whether it's in the heart or brain or anywhere else.
Okay, next question.
In the senior population, is it a good preventive medicine to just take a small blood pressure pill every day?
Yeah, if your doctor recommends it, I don't want to usurp what your doctor recommends, but if you have high blood pressure, take the pill. Now, sometimes you have to up the dose or down the dose depending on your blood pressure. And you should have a serial measurement of your blood pressure. I don't want you to get too obsessed over this, but if you are hypertensive and you take medication and you have a blood pressure cuff or a watch or whatever, try and record it like a graph. Make believe you're back in junior high school and you're grafting it. And your doctor, you can then show it to your doctor. And if it's bouncing all over the place, they'll adjust your medication or change it. Or if, I think the battery just died.
Yeah, Selena, his mic went on.
I think it's flashing. Did I answer it?
Yes,
Yeah.
thank you.
Okay, next question.
Yes.
There, turn back on.
I'm in trouble.
Yeah, I can't. Dr. Steve, I realize you have a lot of experience in transplant surgery. If a woman needs a heart and there are none available in the area except for a man, can a man's heart successfully work in a woman and vice versa? Men, could they, if only available heart is from a woman, would that work?
Absolutely. Either one. We do have some criteria. Obviously, you want to note the genetics of the person and the heart. And you also want to know a body size. Now, we've put normal size hearts into children. If they'll fit, you want to make sure it fits. Now, if I have a minute, I'll tell you a very quick personal story. I had a woman, a very nice lady, who went into severe heart failure after she had her baby, postpartum heart failure. And she was on the transplant list. We called her and said, we have a heart for you. Well, is it a man's heart or a woman's heart? You're not supposed to disclose this, but I said, well, it's a man's heart. I won't take it. I said, you're at risk for dying. She waited for a woman's heart. She survived, but
Wow.
well, then let me another real quick story. Genetics. We know about genetics. I did a heart transplant on a rancher, kind of a tough guy from Missouri, cattle rancher. He needed a heart. He was in his early 50s and so forth. So I transplanted him, and he went home in a week or 10 days and was doing fine. And his wife called me and said, he's acting funny. I said, in what way? Come on in. You know, so they came in the office and said, he's found the feminine size. He goes shopping with me. He wants to buy me negligees and all this. So I looked it up, and he got a woman's heart. And I'm at a conference, and I'm talking to liver transplant people. You know, we have all these subgroups of people. And the liver is a big organ with lots of genetics behind it. And they looked at me and said, oh, that's genetic memory. I said, really? Yeah. So that's, you know, that happens.
Okay, next question.
Could you speak to the, whether or not you should have diagnosis and, say, surgery or some resolution before you have perceivable symptoms, as opposed to waiting until you have perceivable symptoms?
Well, it's a tough question because people don't realize they have symptoms sometimes. You know, we all do this. We will downsize our activities and lifestyle. And we should recognize that. And your doc should recognize that if you do a yearly physical. Yes, in certain circumstances. There was a doctor colleague of mine who was playing tennis and died suddenly, 49 years old. I had an autopsy. They showed he had severe coronary disease. At the funeral, I almost passed out because he had a twin brother who lived in a different city who was there. I said, my God, I thought he was dead. And so really, perhaps medically, ethically, and appropriately, I said to him, you need to have an angiogram. He was asymptomatic, or at least he thought he was. He had the same killer lesions in his arteries, and we bypassed it. And he's doing fine. So you should be aware, even though you don't think you have symptoms, you probably do have some indication.
Doctor, we're going to take 2 Zoom questions right now, and then I'll go back to the audience, okay?
Okay.
All right. Here's the first one. Do you feel taking estrogen long-term after early age hysterectomy is safe?
Taking it is safe. Whether or not it'll help with coronary disease, we don't know. The jury is still out on that. It is safe.
Okay. And the next Zoom question, if you have a genetic marker indicating high-risk cardiac event, is there any treatment you would suggest?
I would suggest monitoring very carefully. If there's a family history, you probably have some of that family history. And so make your doctor aware of the family history, and hopefully that doctor will put you through some screening tests periodically.
Okay, next question from Diane.
Hi.
Hi.
A heart murmur. What is the connection with a heart murmur? Is there a risk factor in a heart murmur?
A murmur is a noise. It's the blood flow through an area of the heart that makes a noise. Most murmurs are benign, but if you have a heart murmur, it needs to be investigated. And it is a fairly easy test to do an echocardiogram, which will take a picture of the heart beating and the blood flowing through the heart. Murmurs occur naturally because of flow turbulence, or more likely because there's some disease in one of the valves or in the blood vessel leaving the heart. It doesn't necessarily mean you have to do anything about it, but you should be aware of it.
Okay, next. Next. Okay, next question.
7 hours.
Okay.
Thank you for being on our side for the women. It used to be.
I have no choice.
Okay, good, excellent,
I have a
excellent,
wife and a daughter.
good. But your mother taught you well, though. It used to be that you could use an aspirin, say you're camping or you're somewhere far away, you can't go to an ER. Is it still rule of thumb that you put an aspirin under the tongue?
Oh, yes.
Okay.
If you're out somewhere remotely and you have symptoms, I mean, hopefully it's not an ulcer,
Right.
but stop, pull over the side of the road and take a couple of aspirin and then get yourself somewhere.
Okay, next question.
Thank you for that presentation. Can you hear me?
Did it go off? Okay,
Hello? Yes. Thank you for the presentation. I do have a question, but I'll also say coincidentally, speaking of heart transplants, La Jolla Playhouse is opening a new show. It's called The Heart, and it's about 24 hours in the life of a transplanted heart.
wow.
And I think it's a musical, so who knows? Who knows? But it's 24 hours in the life of a surfer. But I did have a question about the diet. I think we all know the Mediterranean diet. Can you tell us a little more about the DASH diet? I think it's similar. Lots of vegetables.
It's very similar. It's the same, low fat, high protein, lots of grains and things like that. It's just one of the whole variety. Perhaps someone else in the audience
Let me go to that.
knows the details about it.
Forgot about it.
I don't eat at McDonald's, but I have a monitor that takes care of me.
Okay, here we go again.
And just a quick comment about the heart. In the early days of transplant, the families of the donor and the recipients would all meet, have dinner and a dance. But because of issues, it became unethical to do that because people were being extorted. You have my son's heart, I need some money. So it's all blinded now. It's amazing. It's just amazing. We never thought about things like that.
Okay, the next question is from Howard without a microphone.
With the microphone.
Oh, with the microphone. Okay,
There's been a wave of TV and media advertisement for things like Mounjaro, Wegovy, and I was wondering what your assessment of those was as it might relate to the heart.
When I started medicine and through all my years in medicine, you weren't allowed to advertise things like that. And then suddenly it all changed. They're all efficacious. The companies spend hundreds of millions of dollars to develop these drugs. They all have a use, but you can't just go out and get one, even though you think you may want it. Your doctor really needs to guide you. Listen to those commercials, be informed, and make an intelligent decision with your physician.
next question from Charlie Martolio.
Hi, Steve. Would you talk for a second about the value and efficacy of wearables? Apple Watches, rings, that's.
Yeah, they're very helpful. It's a step forward. My only caution would be is don't overreact too much to it and don't depend too much on it. But a quick story. Around 2002, 2003, we had a bunch of money at the NIH to do something called the National Heart Attack Alert Program. And it was about the fact that when people were symptomatic with heart disease, the average time it took someone to go to an emergency room was about 50 minutes. So we spent a lot of money and a lot of time educating people all over the country about symptoms and when you should go and so forth. And it turned out that the average time increased to about an hour and a half.
Oh,
But people couldn't make a decision.
wow.
So it was before this technology, and our group was trying to develop a Dick Tracy watch. In other words, a watch was something that you could wear that picked up abnormalities, heart rate, whatever, blood pressure, EKG, but didn't tell you about the heart rate, EKG, or blood pressure, whatever. It just sent you a signal, you have 30 minutes to live, get to the emergency. Well, it was before our technology. And this technology, I hope will evolve, because you all look at your devices and say, oh, I didn't do 10,000 steps. I have to run across the street. Or, this is bothering me. What should I do about it? None of us are really experts, but AI hopefully will combine all these things and tell you, we found all these different abnormalities. Go see your doctor, or go to the emergency room, or, use a pitching wedge rather than a sand wedge.
Okay, next question.
Yes, I have a question and a comment. At what age should women have tests done to make sure that their heart is okay? And what tests would you suggest? And then my comment is, if a woman is having a heart attack, bring a male with you, because otherwise they treat very often women different than men.
That's horrible. It's my recognition that if you go to the emergency room and you just say, I'm having chest pain, even if you're not, and you're a gal that has these other symptoms, I'm having chest pain, they respond like this. At menopause, you should begin thinking about, unless you have a genetic history and so forth, but if you're perfectly healthy and normal, a routine checkup, a treadmill test, and even though you may not have chest pain on the treadmill test, if you have those other symptoms that I talked about, sudden fatigue or increased heart rate, that should be a red flag to go on to the next step.
Okay, next question.
Oh. Hi. On one of the
Okay.
on one of the slides that you showed, there were 4 categories of disease, and on the bottom line, one was Raynaud's. And what category would you put that in, and is there a treatment?
Raynaud's, that's spasm of the arteries, and it's more typical in your hands and feet when you're exposed to cold. And the treatment usually is a calcium blocker, which is a dilator of the blood vessels, a beta blocker or calcium blocker. Now, again, I keep going back to your doctor, but they would have to regulate that, because not everybody can tolerate those medications at certain doses. So you need to be fine-tuned. But that's spasm.
It's a statin.
Spasm.
Thank you very much, Dr. Phillips.
That was very informative. Thank you, Serena.
So September 26th, our next program on cybersecurity. We look forward to having more of you come next month. And thank you for coming today. Thank you, Dr. Phillips.